Great, so let's move into the kind of what is the future going to look like, and is our care on the ability to actually risk stratify and use drug monitoring and the use of dashboards in clinical practice to help us even optimize our personalization strategies more. So what is personalized healthcare? How are we defining it, and what does it really mean to say it's a very sexy term to talk about personalization and precision medicine, and what does that really mean? It's really customized healthcare. It's an innovative approach, in essence, also to disease prevention and treatment that takes into account really the environment, the individual genetics, and their lifestyle. And it encompasses individual susceptibility to disease, diagnosis, management of the disease, and I do also want to distinguish precision health, which is a lot of this tight control disease monitoring that both of you have addressed, versus using pharmacogenetics and pharmacogenomics to kind of decide which treatment you're going to go onto. So what are the major clinical questions confronting us in IBD? If we pose the three probably that are plaguing us the most in terms of being able to raise our game and practice a more personalized approach would be, can we predict the disease course and risk of complications? How do we personalize our treatments to select the most effective therapy for the individual patient that is sitting in front of me? And how do we keep patients well in that very tight control box and optimize the treatments? So I'm sure you've seen this slide so many times at every Sympo, and it really is, I don't think we can say it enough, the idea, particularly in Crohn's disease, some would argue as well in the ulcerative colitis undertreated patient or progressive patient, is that Crohn's disease in particular is a progressive disease. And every time we were giving steroids in the good old boys days, was that you were essentially just kind of whack-a-moling the inflammation, but you weren't changing the biology. If you're not changing the biology, the bowel wall damage continues to progress, and you're really not getting at the underlying matter of what is turning on that inflammatory cascade. The patient feels better as you're kind of pushing down the anti-inflammatory effect of the steroids, but you're not doing anything to the natural history of the disease, and hence this kind of progression on. And really the question is, if our goal of treatment is to flatline essentially that natural progression, do we have the treatment strategies? Do we have the tools? Do we feel confident enough in the target that we actually have chosen to be able to actually really say that we can change this natural history and progression and trajectory of the disease? The question is how. When we talk about it, I think what you hear also, not just about that, bowel wall damage occurs, and Bruce showed you the the Le Mans index in terms of the change in the Le Mans index, particularly people have CRPs that are still elevated. I feel great, but this, again, this progression is occurring and the bowel wall damage is progressing, is that if we were to treat the disease early in its pure inflammatory state, before fibrosis has begun to set in, before collagen deposition, would we be able to change the natural history and really abort that cycle and the trajectory? How could early intervention work? There's a number of things that need to go into everyone saying, let's just find that window, treat early. The question is, how, what are the tools and what are the steps we need to do to make these patients really identify them early? You need a way of identifying somewhat of a red flag type of checklist, and the group from Milan with Silvio Donesi, I don't know if he showed his red flag at the meeting this past couple of days, but they've been able to disseminate it to the primary care physicians because of the way the referral structures were working, and basically almost think of it as a smart set where these are the symptoms that trigger you or your healthcare system in the EPIC chart, for example, that says patients should see a gastroenterologist quickly. Essentially, this isn't about you saying, I think you have IBS, come back, and I'll see you if your symptoms don't change. Avoid some lactose, maybe have some Metamucil, and all along while this is happening, the patient's bowel wall is continuing to be damaged. You need a way of rapid referral. You need a way of getting people in early. Early intervention will require us understanding that we don't want to overtreat 100% of patients, But the question is, if 85% of patients are designated moderate to high risk, you're only, I say only, I'm not saying, I don't take it lightly, but you'd be over-treating maybe 15% of patients if you assumed coming into your office until you've gotten all the parts of the puzzle that this patient should be on effective therapy. And what does that mean? And also personalization, which everyone's been speaking to about choosing the right drug for the right patient. We think the right time is early, and it's a matter of getting the patient to the skilled gastroenterologist to be able to decide what treatment that should look like, and also how do I keep them well, and that's where the TDM piece will come in a minute. And one of the things, as we all have known, we've been talking about it since 2006 at DDW in LA. The first Sunday morning session, never had we had a title called The Natural History of IBD. No one even talked about that we could actually predict, maybe with some tools that we already had, this was over a decade ago, that we were able to say that there are certain patients who have what we call disabling Crohn's disease. That was the first introduction of this idea that Crohn's is disabling, but interestingly, the definition of disabling was needing a biologic. So that was the definition of disabling, meaning you had to go from beyond prednisone and needing immunomodulator, needing surgery, and on the same page or the same definition was needing a biologic. So those of us would say that you're not really disabling until you've had natural, the progression and the bowel wall damage has occurred in the absence of potentially a biologic, and knowing that there is definitely a spectrum of risk stratification and that not all patients are alike. The question that has always posed to all of us who are kind of really hot on this idea of being able to risk stratify patients is, do we have the tools right now to say, if I had a patient who walked in the door tomorrow, is my crystal ball there? Do I have enough of the parts of the ball that I can really predict that my patient is going to be a patient who's going to progress? Bruce showed you kind of the things that are in the clinical care pathway. Less than 30, I would have to argue that someone who's 12 is different than someone who's 29. We learned that from the Vienna classification, David, that less than 40, we didn't really move the needle. We only went down a decade. There's a lot of difference between someone who's a teenage onset with severe growth failure, long segment, jejunal disease. These are very different patient populations, so it's beyond age. Endoscopic, meaning does the depth of the ulceration mean anything? Maybe, because the minute you break beyond the mucosa and you go beyond apthi, you're automatically talking about a patient who really goes beyond, please God, a 5-ASA or an antibiotic, which tends to, as you know, be probably one of the most commonly prescribed first-line Crohn's disease management, regardless of risk factors. So I think these are important take-home points to say that we need to get better at predicting imaging. Maybe if we actually think the Lamont Index is a way of stratifying patients based on risk of progression or using length of segment, bowel wall thickness. We know that once a patient starts to have already maybe some changes in terms of stricturing, thinking about using diffusion or advanced techniques with your MR interrographer to start to tell you that you're already getting this bowel wall damage, so you need to speed it up. Genetically, believe it or not, since 2001 when NOD2 was discovered, it still remains the fact that we don't really have genetics that predict prognosis. NOD2 is probably the closest in terms of its showing association with terminal ileal disease and some stricturing complications and some post-op recurrence. But despite almost 300 genes, we really don't have a genetic test that actually predicts prognosis. Serologies, we've been struggling with the idea of what do serologies mean. At first we've come very far because we came from the idea that ASCA was a Crohn's marker, Pianka was a UC marker, and we've really transitioned to the idea that serologies mean something much more than you have this type of subtype of IBD. It means that you have global loss of tolerance to the bacteria, you have a lot of inflammation, and we now know that even serologies are present before disease presents. And not only are they present, the height of the antibody response gets higher as you get closer to diagnosis. So whether it's going to be ASCA or whether it's going to be serology B, I'm not sure what it's going to look like, but there's definitely going to be an interest in looking at markers that are present before diagnosis, so that maybe those are markers of earlier disease. In terms of fecal microbiome, so far as I've noted, there hasn't really been very many predictors. There's some hints of some microbiome profiles that are increased in certain patients who have complication, and the role of calprotectin has never really been tied to a prognosis. It's just been tied to predicting flare potentially, and maybe using it as Bruce showed you from the Stride manuscript. We really back then, and that was a while ago, so I think we're getting a little bit more confident in the predictability of calprotectin, but maybe for Crohn's in particular, small bowel Crohn's, if some patients don't make CRP and calpro's not that great for ileal disease, we're missing the marker. And maybe that's why COM, less than 50%, met the primary outcome. Maybe it's not the best biomarker for us to follow. So these are things, again, and there's some interest in some of these antibodies and proteomics and other ways of gene expression. Speaking of gene expression, so the risk cohort, which you may have seen our paper from Lancet, which is our pediatric cohort of 1,000 pediatric patients that were newly diagnosed. We got stools, we got mucosal biopsy expression, we got serologies, and we have the demographics and genetics. One thing that is interesting is that despite 10 years ago, we published on serologies predicting prognosis in a prospective cohort, because that was always the argument. You're getting these serologies retrospectively, these are after the fact, these aren't really a true prospective sampling, that, believe it or not, serologies was probably the strongest predictor that a pediatric patient who's uncomplicated at diagnosis becomes complicated within 36 months of presentation. One thing, I think the reason why our paper really got into Lancet was this new concept that maybe it's even beyond that, you go right to the tissue, and that those patients who have extracellular matrix gene expression, this is more collagen and really the fibrosis setting in, that at diagnosis, those patients actually went on to have stricturing complication. So these were patients who we declared non-penetrating, non-stricturing, but at the gene expression level of the ileum predicted that that patient was going to get stricturing complication. And more importantly, in pediatric patients, early TNF therapy within 90 days did not change the natural history of developing stricturing Crohn's disease in pediatric patients. Probably because their ECM matrix deposition and their expression was high. So these are where we're going to, that it could be that TNF is not the right treatment for someone who's already got markers of gene expression for stricturing disease. So it's an exciting time in our field looking at predictors of using gene expression and potentially even proteomics. So the question is, how do I put all this together? There's not a lab that I'm dropping an ileal biopsy in that it's telling me what the ECM matrix is, and now BulkSeq, which is running sort of kind of a fishing experiment to really find what are some of the expressions I need to think about. You've seen the Prospect tool, probably Corey maybe has shown it just like over 100 times in the last 24 hours, but this is mine and Corey's tool, and called the Prospect tool, where we actually have put in a lot of these inputs from 10 years ago with the pediatric cohort, where we showed that we were able to actually, in a visual real-time display way, be able to put inputs for the individual patient sitting in front of you and put in their serologies, their age, their disease duration, their personal characteristics, disease location, and it essentially prints out, are you low, moderate, or high risk? And this was, I'm showing you the data from our first 100 patients that we presented at DDW. We've now closed enrollment. We've met our 200 or so patient mark. And what was interesting is if you took newly diagnosed, or essentially the mean duration of disease was 1 year, 4 months, if you took these patients and you predicted how many out of 100 patients who walked in your office, how many would be predicted to have mild disease? Less than 15% of the patients, using the patient's personal characteristics, would be actually predictive to not complicate. The risk is for developing complications. And you could see that the majority of our patients are moderate, but you've got a significant amount, almost 40% of patients who are high risk. And the next question you need to ask is, does the tool actually, is it real? Meaning, do those patients who are actually predicted to complicate, did they actually complicate? Not that we want that to happen because we'd like to prove ourselves wrong that people didn't complicate, but as a matter of fact, the group with the most number of patients that were predicted to be complicated was the group that complicated with predominance, and only a small proportion of our moderate or our minimal risk prediction actually complicated. And now we're looking at, does the ability to see your visual actually change your choice of treatment? Would you buy more into what the doctor is selling, the idea that we want to treat people earlier and we have a tool that could help you communicate to the patient, show them what their risk trajectory is, and have them hopefully buy into whatever you want them to actually be on, because together we have a shared decision making on risk. So the era of one drug fits all, we think, is over. Personalized medicine, we're moving from that current paradigm of kind of like, let's throw the, keep our fingers crossed, hope that you respond, and if you don't, move on to the second. And if you don't respond to the second, we move on to the third. I think we've kind of learned our lesson over the last 24 or 48 hours, where we know that the sequence at which you give the therapy matters. So it does matter if you give a TNF first for its impact on integrins or the IL-12/23. So maybe you do need to choose wisely, and maybe the importance of understanding the biology of the patient sitting in front of you will actually help you decide which treatment should I choose. We didn't have, as Russ noted, that we didn't have such difficulty or such plethora of riches when we just had one class. I remember always like the idea of thinking about personalization, and I would always end by saying, well, how much help am I really, because there's only one class of therapy. Now it sounds a little bit more interesting that we have, particularly in Crohn's, 3 classes available. So this personalization where you hope you get from, at a year, 35% of patients in remission, that you want 85, 90% of patients in remission if you choose the right target. And that's how we should be practicing. You don't have an oncologist who understands now that there are 5 kinds of lymphomas. If you actually go to the tissue and you actually see what type of lymphoma, you're not going to use the wrong type of therapy. You're going to go after the biology of the tumor. Same thing needs to apply to IBD for us to move the needle. One thing that's interesting when you think about, I say that no gene has really been tied to prognosis. No gene has really been tied to response to therapy. When NOD2 first came out, we all thought this was it. This is what's going to tell you whether a patient's going to respond to TNF therapy, because NOD2, granulomas, TNF, it all makes sense. Absolutely flat. There was absolutely no role of NOD2 in predicting whether or not you would be a responder to TNF. So what's interesting about this table is that ustekinumab is not approved for rheumatoid arthritis. People were, how is this possible? Every other drug almost that we had, for example, the TNF space, psoriasis, rheumatoid arthritis, IBD, across the board. Well, the red circle shows you a blank, and that's because the IL-23 receptor gene, which was kind of like the second popular gene after NOD2 was discovered, is actually not present in rheumatoid arthritis patients. So why would an IL-12/23 blockade work? And that's why it's approved for psoriasis, psoriatic arthritis, and Crohn's disease. So we started to understand that maybe if I can measure the IL-23 receptor as a gene test out there, I may be able to start segmenting my patient into which patient would be better served by an IL-12/23 blockade, or IL-23 blockade probably even more, versus a TNF or integrin base. So I think we've got a lot of excitement. One of the other things, Russ mentioned IL-22. What's interesting, and Bruce could speak more to it because he looked at it in the IL-23 target for when it was MedImmune Amgen, originally in the phase 2A, but moving that forward, could it be that we're going to have a biomarker that we may be able to measure at a lab that actually says that that patient should do well with this target, not just the gene that I just mentioned, but actually a protein, or measuring an ELISA assay, maybe something as simple as that. And what this graph actually shows you, that at baseline, patients that had higher IL-22 levels actually responded better to the IL-23 target. So I think this is an interesting thing that we're going to be exploring in clinic and hopefully available at some commercial lab. I know our immunologists are excited about exploring that in our clinic as well. Another example is Etrolizumab response and Integrin expression. This was another example of a biomarker that may actually help know whether or not a patient will respond to Etro, is that there was the alpha-4 E7, both found in the colonic biopsies and gene expression. And so it was shown that patients did better if you were actually expressing the alpha-4 E7. So again, this is just kind of hinting at the ideas that we're looking for ways where we can choose the right therapy for the right patient. So I'll finish my lecture about talking about the future of therapeutic drug monitoring. We've evolved so much from that reactive algorithm, and although I respect both of these good old boys beside me over here, this kind of sheriff, female sheriff, yes, is actually saying that how you dose it in a reactive way, and if you want to wait for a patient to have low drug levels and develop ATIs, that's the end of the game. What you really need to think about is how in induction can I figure out the dose? Because if I get the induction right, the maintenance is going to go really well. And more importantly, how can I actually choose my dose based on the patient that is once again sitting in front of me and not using population pharmacokinetics to make a decision on a dose? It means that we are assuming everyone has the same clearance, the same BMI, the same albumin, the same CRP, the same drug level. But that's impossible, right? Everyone in the room would clear the drug differently. So this is something called iDOSE that myself and Diane Mold, who's a wonderful collaborator and pharmacologist, she has this iDOSE pharmacokinetic model, which is simply a decision support tool that you load all the patient characteristics into. You enter the patient's information, and then you put their gender, you update the information with disease activity, we're actually adding drug levels, and we actually set the trough as what I want my trough level to be. And it will tell me to the date and to the dose when my patient needs to come back for their next dose and what the dose actually is based on the clearance of that patient. And we now know what week 2 levels should be, we know what week 6 levels should be, and we know when your 4th infusion should be. I'll give you an example of a case. These are just some of the printouts that we get, and you can basically, it's kind of fun because you can toggle the trough and you can see whatever trough you want, and it gives you 4 dosing options based on the timing of when you want to bring the patient back. This is a perfect example of what happens in our practice, is that we give 0, 2, 6, and we say, I'll see you at week 14. And the patient sits in the chair, and guess what? Their level's going to be 3.48, and I want them to have a level of 10. So by putting in the patient's drug level, their albumin, their CRP, their disease activity, their BMI, their gender, it actually told me that if I bring the patient back at 4 weeks and 4 days from their 3rd infusion, I will achieve my trough level of 10. And I'd like you to know that 81% of your patients will have an induction and 4th infusion completely off-label, just so you know. So, but the FDA is aware. They're actually working with us to actually plan a clinical trial using this PK model compared to standard of care, because they recognize that we are not dosing biologics correctly, particularly TNF. So how are we going to personalize medicine? It's complex. We have multiple signals that are coming into us, but at the end of the game, it really makes a difference because you will forever change that natural history of the patient if we understand the window of opportunity and we actually treat the patient like the individual that they are sitting in front of you. So thank you so much for your attention.